Question 1. A 45-year-old male presents with hyperparathyroidism. The surgeon performs an exploration of the neck and excises a single parathyroid adenoma. A. 60,500. B. 60,502. C. 60,505. D. 60,512. Answer: A. 60,500. This question tests the coding of parathyroidectomy procedures, with the keyword single parathyroid adenoma indicating a localized excision. Code 60500 describes parathyroidectomy with exploration of the neck, typically for a single gland removal due to an adenoma. The other codes, such as 60502 and 60505, are for more complex scenarios involving multiple glands, previous surgery, or substernal removal. For example, if the surgeon found and removed only one abnormal gland, 60500 is the correct choice. Always remember to choose the most specific code that accurately reflects the extent of the procedure performed. Question 2. A patient with a history of thyroid cancer undergoes a total thyroidectomy. Due to the extent of the disease, the surgeon also performs a radical neck dissection on the right side. A. 60,240, 38720 RT. B. 60,260. C. 60,254. D. 60,240, 38500 RT. Answer: B. 60,260. This scenario involves coding a total thyroidectomy performed in conjunction with a radical neck dissection. The keyword total thyroidectomy combined with radical neck dissection is crucial. CPT code 60260 specifically describes a total thyroidectomy with a radical neck dissection, unilateral, encompassing both procedures within a single code. Therefore, it is inappropriate to code the thyroidectomy and neck dissection separately. For example, if the entire thyroid gland and lymph nodes from one side of the neck are removed, 60,260 bundles these services. Always review the full code description to ensure all components of a procedure are included in a single, comprehensive code. Question 3. A 62-year-old patient with Cushing's syndrome undergoes a laparoscopic total adrenalectomy of the left adrenal gland. A. 60540 LT. B. 60545 LT. C. 60650 LT. D. 60659 LT. Answer: C. 60650 LT. The concept here is coding an adrenalectomy based on the surgical approach, specifically a laparoscopic procedure. The keywords are laparoscopic and total adrenalectomy. Code 60650 describes a laparoscopic adrenalectomy, and since it was performed on the left side, the LT modifier is appended. Codes 60540 and 60545 are for open adrenalectomy procedures. For example, if the surgeon used small incisions and a camera to remove the left adrenal gland, 60650 LT is the correct code. Remember to differentiate between open and laparoscopic approaches, as they often have distinct CPT codes. Question 4. A 30-year-old female presents with a thyroid nodule. The physician performs a fine needle aspiration, FNA, biopsy of the thyroid nodule, utilizing ultrasound guidance. A. 60,100. B. 60,100, 76,942. C. 10,005, 76,942. D. 10,021, 76,942. Answer, D. 10021, 76,942. This question addresses the coding for a fine needle aspiration, FNA, biopsy with imaging guidance. While CPT code 10021 specifically describes an FNA without imaging guidance, and newer codes, 10004-10012, exist for image-guided FNA, test questions sometimes present 10,021 as the biopsy component when imaging guidance, 76942 for ultrasound E, is reported separately. The correct approach for an FNA of a single superficial lesion, like the thyroid E, with ultrasound guidance, according to current CPT, would typically involve code 10005 for the biopsy and 76942 for the guidance. However, given the options, 10021 is often seen paired with the guidance code 76942 in practice exams to represent the biopsy and its guidance. When coding, always ensure you identify both the biopsy procedure and any imaging guidance performed. Question 5. A patient undergoes an initial thyroid lobectomy, right lobe, for a benign follicular adenoma. A. 60,210. B. 60,212. C. 60,220. D. 60,240. Answer, A. 60,210. This question focuses on coding a partial thyroidectomy, specifically a lobectomy for a benign condition. The keywords are initial thyroid lobectomy and benign follicular adenoma. CPT code 60210 is used for a partial thyroid lobectomy, unilateral, for an initial surgery for a benign lesion. Codes like 60212 are for recurrent or more extensive benign disease, while 60220 is for malignant disease. For instance, if only half of the thyroid is removed due to a non-cancerous growth, 60210 accurately reflects this. Always confirm if the procedure is initial or recurrent and if the pathology is benign or malignant, as this significantly impacts code selection. Question 6. A surgeon performs an open total adrenalectomy on the right side. The patient has a large pheochromocytoma. A. 60540 RT. B. 60545 RT. C. 60600 RT. D. 60520 RT. Answer, A. 60540 RT. This scenario involves coding an open total adrenalectomy. The keywords are open total adrenalectomy and right side. Code 60540 is specifically for an open adrenalectomy, unilateral, for a single gland. Code 60545 is for a more complex adrenalectomy involving a previously operated field or a very large tumor requiring specific surgical considerations, which is not indicated here beyond large pheochromocytoma that doesn't necessarily elevate it to 60,545 without further detail. For example, if a surgeon makes a direct incision to remove one entire adrenal gland, 60540 is the appropriate code. Always select the code that best describes the extent and approach of the open procedure. Question 7. A patient has a hyperfunctioning thyroid adenoma and undergoes a subtotal thyroidectomy. A. 60,210. B. 60,220. C. 60,200. D. 60,225. Answer, C. 60,200. This question tests the coding of a subtotal thyroidectomy for a specific condition. The keywords are hyperfunctioning thyroid adenoma and subtotal thyroidectomy. CPT code 60200 is designated for excision of a thyroid adenoma or nodule, typically representing a limited or subtotal removal of the gland. Codes like 60210 or 60220 represent a lobectomy for benign or malignant conditions respectively, which is a more defined removal of a lobe rather than a simple excision of a nodule within the gland. For instance, if a specific overactive nodule is removed, preserving most of the gland, 60200 is the correct choice. Pay close attention to the extent of the excision, e.g., nodule, subtotal, lobectomy, total, when selecting thyroid surgery codes. Question 8. A 55-year-old female presents with recurrent hyperparathyroidism. She previously had a parathyroidectomy. The surgeon performs a re-exploration of the neck with excision of a parathyroid adenoma. A. 60,500. B. 60,502. C. 60,505. D. 60,512. Answer, B. 60,502. This question focuses on coding a parathyroidectomy when it is a repeat procedure. The keywords recurrent hyperparathyroidism and re-exploration of the neck are critical clues. Code 60502 is specifically for parathyroidectomy, re-exploration, or secondary exploration in a previously operated area, which applies directly to a patient undergoing a repeat surgery. Code 60500 is for an initial exploration, and 60505 is for substernal gland removal. If a patient requires another parathyroid surgery after a prior one, 60,502 correctly captures the increased complexity of operating in a scarred field. Remember that previous surgery in the same area often warrants a different, more specific CPT code. Question 9. A patient undergoes exploration of the parathyroid glands. The surgeon identifies and removes two hyperplastic parathyroid glands. A. 60,500. B. 60,502. C. 60,505. D. 60,512. Answer, D. 60,512. This question tests the coding for removal of multiple parathyroid glands. The keywords are exploration of the parathyroid glands and removes two hyperplastic parathyroid glands. CPT code 60512 is an add-on code for the removal of additional parathyroid glands, beyond the first one removed, often used when hyperplasia leads to removal of multiple glands. If the primary exploration and removal of the first gland is 60,500, then 60512 would be appended for the second gland. Therefore, you would report 60500 for the first gland and plus 60,512 for the second gland. This scenario implies the removal of more than one, thus 60512 is the primary option among the choices representing this. Question 10. A surgeon performs a total thyroidectomy for follicular carcinoma. The procedure also involves a central compartment neck dissection. A. 60,240. B. 60,252. C. 60,254. D. 60,260. Answer, B. 60,252. This question tests the coding of a total thyroidectomy for malignancy that includes a specific type of neck dissection. The keywords are total thyroidectomy, follicular carcinoma, and central compartment neck dissection. CPT code 60252 describes a total thyroidectomy for malignancy, which includes a limited neck dissection, such as a central compartment dissection. Code 60254 is for a more extensive procedure involving radical neck dissection, while 60240 is for a total thyroidectomy without any specified neck dissection. For example, if the entire thyroid and the lymph nodes immediately surrounding the trachea are removed for cancer, 60252 is the appropriate code. Always distinguish between different types and extents of neck dissections when coding thyroidectomies for malignancy. Question 11. A 70-year-old male with a history of thyroid cancer, previously treated with total thyroidectomy, now presents with a recurrent thyroid tumor. The surgeon performs an extensive re-excision of recurrent thyroid tumor, S, with removal of sternocleidomastoid muscle. A. 60,260. B. 60,254. C. 60,252. D. 60,240. Answer B. 60,254. This question describes a complex, recurrent thyroidectomy for malignancy involving extensive removal. The keywords recurrent thyroid tumor, S, and extensive re-excision plus removal of sternocleidomastoid muscle are key indicators. CPT code 60254 is used for a total or subtotal thyroidectomy for malignancy, with a radical neck dissection, which often involves the removal of muscles like the sternocleidomastoid, particularly in cases of recurrence and extensive disease. Codes 60252 and 60260 are for less extensive dissections or for total thyroidectomy with a radical neck dissection that doesn't necessarily imply recurrence with such extensive involvement. For example, if a patient has a large, recurring thyroid cancer requiring removal of the gland and extensive lymph nodes and surrounding muscle, 60254 is the most accurate code. Pay close attention to the extent of the tumor, the history of recurrence, and the structures removed during neck dissections. Question 12. Excision of a carotid body tumor, without excision of the carotid artery, performed via a neck incision. A. 60,600. B. 60,605. C. 35,301. D. 35,450. Answer A. 60,600. This question tests the coding for the excision of a carotid body tumor. The crucial keyword is carotid body tumor and without excision of the carotid artery. CPT code 60600 specifically describes the excision of a carotid body tumor, without the removal or repair of the carotid artery itself. Code 60605 would be used if the carotid artery also required resection and repair. Vascular codes like 35,301 or 35,450 relate to endarterectomy or angioplasty, not tumor excision. If a surgeon removes a growth from the carotid body, carefully dissecting it away from the artery, 60600 is the correct code. Always differentiate between procedures that only remove the tumor and those that also involve the associated vascular structures. Question 13. A patient undergoes bilateral total adrenalectomies, performed via an open incision. A. 60,540 to 50. B. 60,540 to 50, 60,540 to 59. C. 60,540, 60,540 to 51. D. 60,540, 60,540 to 50. Answer A. 60,540 to 50. This question addresses the coding for a bilateral surgical procedure. The keywords are bilateral total adrenalectomies and open incision. CPT code 60540 describes a unilateral open adrenalectomy. When the same procedure is performed on both sides during the same operative session, the -50 modifier, bilateral procedure, is appended to the single code. It is incorrect to report the code twice with separate modifiers like -51 or -59, as -50 indicates the bilateral nature of the procedure. For example, if both adrenal glands are removed through open surgery, 60,540 to 50 accurately conveys that the procedure was done on both sides. Remember to use the -50 modifier for bilateral procedures unless the CPT code itself explicitly states bilateral. Question 14. A 28-year-old female presents with symptoms of hyperthyroidism. Following appropriate workup, she undergoes an excision of a thyroglossal duct cyst, without a bone division. A. 60,200. B. 60,210. C. 60,000. D. 60,280. Answer, D. 60,280. This question tests the coding for the excision of a specific congenital anomaly in the neck. The keywords are excision of a thyroglossal duct cyst and without bone division. CPT code 60280 is specifically for the excision of a thyroglossal duct cyst or sinus, without the division of the hyoid bone. Code 60281 would be used if the hyoid bone division was necessary. The other codes listed are for thyroid gland procedures, not for a thyroglossal duct cyst. For instance, if a surgeon removes a fluid-filled sac from the neck that is a remnant of the embryonic thyroid development, and does not need to cut the hyoid bone, 60280 is the correct code. Always look for codes specific to congenital anomalies or cysts rather than assuming it falls under general gland excision. Question 15. A patient with a mediastinal mass undergoes an open total thymectomy. A. 60,520. B. 60,521. C. 60,522. D. 60,540. Answer, A. 60,520. This question focuses on coding a thymectomy performed via an open approach. The keywords are open total thymectomy and mediastinal mass. CPT code 60520 is for a thymectomy, partial or total, performed via the cervical approach, neck incision. Code 60521 is for a total thymectomy performed via a sternal split or transthoracic approach, which is a more extensive open approach. Code 60522 is for an open approach with a mediastinal dissection. Assuming a standard open approach not specifically listed as sternal split or requiring extensive mediastinal dissection beyond the thymectomy itself, 60520 is the most appropriate code for an open total thymectomy without further complicating factors. Therefore, for a total thymectomy through a standard open incision, 60520 is typically used unless further details suggest a more complex approach. Question 16. A 40-year-old patient undergoes an open partial thymectomy for myasthenia gravis, performed through a transcervical approach. A. 60,520. B. 60,521. C. 60,522. D. 60,500. Answer, A. 60,520. This question describes a partial thymectomy performed through a specific open approach. The keywords are open partial thymectomy and transcervical approach. CPT code 60520 covers both partial or total thymectomy performed via the cervical, neck, approach. Code 60521 and 60522 describe more extensive open approaches, such as sternal split or transthoracic. Therefore, for a partial removal of the thymus through an incision in the neck, 60520 is the correct code. Remember to identify the extent of the thymectomy, partial or total, and the surgical approach, cervical, sternal split, transthoracic, for accurate code selection. Question 17. A patient with primary hyperparathyroidism undergoes a mediastinal exploration for ectopic parathyroid adenoma, requiring a sternal split. The adenoma is identified and removed. A. 60,500. B. 60,505. C. 60,520. D. 39,010. Answer, B. 60,505. This question involves an exploration for an ectopic parathyroid gland in a difficult location. The keywords mediastinal exploration, ectopic parathyroid adenoma, and requiring a sternal split are crucial. CPT code 60505 specifically describes parathyroidectomy, with mediastinal exploration, requiring a sternal split or transthoracic approach. This code accounts for the increased complexity and invasiveness of accessing the parathyroid gland within the chest. Codes like 60,500 are for neck explorations, and 60520 is for thymectomy. When a parathyroid gland is located in the chest and requires opening the sternum for removal, 60505 is the appropriate code. Always check the anatomical location of the gland and the surgical approach for accurate coding of parathyroid procedures. Question 18. A 35-year-old patient undergoes a total thyroidectomy for Graves' disease. A. 60,220. B. 60,240. C. 60,252. D. 60,260. Answer, B. 60,240. This question describes a total thyroidectomy performed for a non-malignant condition. The keywords are total thyroidectomy and Graves' disease, which is a benign condition, albeit requiring extensive removal. CPT code 60240 is for a total thyroidectomy without any specified lymph node dissection, appropriate for benign conditions or malignancy without extensive nodal involvement requiring separate dissection. Codes 60220 and 60252 are for malignant conditions or include specific neck dissections. For example, if the entire thyroid gland is removed due to hyperthyroidism like Graves' disease, and no cancer or lymph node removal is documented, 60240 is the correct choice. Always distinguish between thyroidectomies for benign versus malignant conditions and the extent of any associated lymphadenectomy. Question 19. A patient is diagnosed with a recurrent thyroid cyst. The physician performs an excision of a lateral aberrant thyroid tissue. A. 60,280. B. 60,281. C. 60,220. D. 60,225. Answer, D. 60,225. This question deals with the excision of aberrant thyroid tissue, often related to developmental anomalies or remnants. The keywords are excision of a lateral aberrant thyroid tissue and recurrent thyroid cyst. CPT code 60225 describes the excision of a lateral aberrant thyroid tissue, including a cyst or fistula. Codes 60280 and 60281 are for thyroglossal duct cysts, which are located in the midline. For instance, if a patient has a cyst on the side of their neck derived from misplaced thyroid cells, 60225 is the appropriate code. Remember to differentiate between midline thyroglossal cysts and laterally located aberrant thyroid tissue. Question 20. A patient undergoes exploration of the adrenal gland. The surgeon finds a non-functional adenoma and performs a partial adrenalectomy of the left gland. A. 60540 LT. B. 60545 LT. C. 60540 LT with modifier 52. D. 60540 LT, 60545 LT. Answer, C. 60540 LT with modifier 52. This question tests the coding of a partial adrenalectomy when the CPT code typically describes a total adrenalectomy. The keywords are partial adrenalectomy and left gland, performed via an implied open approach, since laparoscopic is usually specified E. CPT code 60540 describes a unilateral open adrenalectomy, which usually means total removal. When only a portion of the gland is removed, modifier -52, reduced services, is appended to 60540 LT to indicate that the full procedure described by the code was not performed. It is inappropriate to use a total adrenalectomy code without modification for a partial removal. For example, if a surgeon removes only a segment of the left adrenal gland through an open incision, 60540 LT with modifier 52 correctly reports this reduced service. Remember to use modifier -52 when a procedure is partially reduced or eliminated at the physician's discretion. Question 21. A patient requires removal of a large, recurrent thyroid goiter that extends substernally. The surgeon performs a subtotal thyroidectomy. A. 60,220. B. 60,225. C. 60,271. D. 60,270. Answer, D. 60,270. This question describes a thyroidectomy involving a substernal extension, which signifies increased complexity. The keywords are large, recurrent thyroid goiter, substernally, and subtotal thyroidectomy. CPT code 60270 is specifically for a thyroidectomy, including removal of substernal thyroid, whether partial or total. This code accounts for the more challenging dissection required when the gland extends into the chest. Code 60220 would be for a subtotal thyroidectomy without this substernal component. For example, if a goiter has grown behind the breastbone and requires a more intricate surgical approach for removal, 60,270 accurately captures this complexity. Always consider anatomical extensions like substernal components when selecting thyroidectomy codes. Question 22. A 48-year-old female presents for placement of markers for future localization of a thyroid nodule. The radiologist places 2 fiducial markers in the thyroid nodule under CT guidance. A. 10,035, 77,012. B. 37,252, 77,012. C. 10,036, 77,012. D. 60,100, 77,012. Answer, C. 10036, 77,012. This question tests the coding for image-guided marker placement for future localization. The keywords are placement of markers, thyroid nodule, and CT guidance. CPT code 10036 is for placement of a soft tissue localization device, e.g., fiducial markers, for future localization, percutaneous, initial lesion. Add-on code 10037 would be used for additional markers. CPT code 77012 is for computed tomography, CT, guidance for needle placement. For example, if a radiologist uses CT to precisely guide the placement of tiny markers into a thyroid nodule for future radiation therapy, 10036 and 77012 are the correct codes. Remember to select both the code for the marker placement and the separate code for the imaging guidance used. Question 23. A surgeon performs a total lobectomy of the right thyroid lobe for papillary carcinoma. A central neck dissection is also performed. A. 60,220. B. 60,225. C. 60,212. D. 60,252. Answer. A. 60,220. This question involves a thyroid lobectomy for malignancy with an associated neck dissection. The keywords are total lobectomy of the right thyroid lobe, papillary carcinoma, and central neck dissection. CPT code 60220 is for a total or subtotal lobectomy, unilateral, for malignancy. When a central neck dissection is performed with a lobectomy for malignancy, it is considered inclusive to 60,220 unless it is a more extensive radical or modified radical neck dissection coded by 60,252 or 60,254. For instance, if only one lobe of the thyroid is removed due to cancer, and nearby central lymph nodes are also cleared, 60,220 typically covers both. Always consider if a specified neck dissection is included or separately reportable with the primary thyroidectomy code. Question 24. A patient has an adrenal mass. The surgeon performs an open exploration of the adrenal gland and removes an adenoma, preserving a significant portion of the adrenal gland. A. 60,540. B. 60,540 to 52. C. 60,545. D. 60,545 to 52. Answer. B. 60,540 to 52. This question describes a partial adrenalectomy performed via an open approach. The keywords are open exploration of the adrenal gland, removes an adenoma, and preserving a significant portion of the adrenal gland. CPT code 60540 is for an open unilateral adrenalectomy, which typically implies total removal. When only a portion of the gland is removed, modifier -52, reduced services, is appended to 60,540 to indicate that the full procedure was not performed. If the procedure was more complex, such as in a previously operated field, 60,545 would be considered, but here the key is the partial removal. Therefore, for an open partial adrenalectomy, 60,540 to 52 correctly reflects the service. Always use modifier -52 when the physician performs a reduced version of a defined CPT procedure. Question 25. A patient with hyperthyroidism undergoes chemical ablation of the thyroid gland. The physician injects alcohol into multiple areas of the thyroid under ultrasound guidance. A. 60,100. B. 60,200. C. 60,300, 76,942. D. 60,300. Answer. C. 60300, 76,942. This question focuses on coding a chemical ablation procedure with imaging guidance. The keywords are chemical ablation of the thyroid gland, injects alcohol, and ultrasound guidance. CPT code 60300 specifically describes the aspiration or injection of a thyroid cyst or gland, which includes chemical ablation. CPT code 76942 is for ultrasonic guidance for needle placement, which is reported separately when performed. Code 60100 is for an open thyroid biopsy, which is not applicable here. For example, if a physician injects a substance to shrink an overactive thyroid nodule using ultrasound to guide the needle, 60300 and 76942 are the correct codes. Remember that when imaging guidance is used for injections, aspirations, or biopsies, both the procedure and the guidance are typically coded.